Hey everyone, and welcome to this explainer. If you've ever stared at a medical scan and wondered exactly how doctors figure out what's really happening inside a complex biological system, well, you're in exactly the right place. Today, we're going to completely demystify a pretty fascinating diagnostic procedure called diuretic renography. We'll break down exactly how clinicians figure out the difference between a kidney that's just harmlessly swollen and one that's truly blocked. And trust me, that's a distinction that can literally save a patient from completely unnecessary surgery.
To do that, here's our roadmap. We're going to start with the dilation dilemma and then move right into the diuresis principle. After that, we'll decode the actual data curves, look at how to avoid some major diagnostic pitfalls, and then bring it all together for the final verdict. Section 1. The dilation dilemma. Is it blocked or just swollen?
Okay, let's jump right in with a fundamental question. Imagine a clinician is looking at an anatomical scan, say a CT or an ultrasound, and they see this massively dilated, swollen collecting system in the kidney. The immediate mystery they have to solve is this. If a kidney is swollen, is it actually blocked? The reality is, static anatomical scans are great at showing us the dilation, but they simply cannot predict the actual urodynamic function. And that leaves us with two very different potential realities for the patient. On one hand, you could have a true mechanical obstruction. Think of a physical blockage here, like a kidney stone, a stricture, or maybe posterior urethral valves. But on the other hand, we have non-obstructed dilation. This might just be a structural abnormality or muscular atony, basically a flabby renal pelvis that's perfectly fine, just a little stretched out with absolutely zero blockage. So the bottom line? You really cannot rely on anatomy alone to make this call. So how do we solve it? Well, this is exactly where nuclear medicine steps in to save the day. Instead of just snapping a static picture of the structure, nuclear medicine assesses the relative, absolute, and excretory function of the kidney in real time. By tracking a radioactive tracer as it's processed by the kidneys, clinicians can definitively separate a dangerous obstructive uropathy from a completely harmless dilation.
Section 2. The diuresis principle. Forcing fluid through a compromised reservoir.
To really wrap our heads around this, let's use a simple analogy. Think of the kidney's collecting system as a funnel. If it's not obstructed, it's a funnel with a nice, wide spout. Fluid drains out normally. But if it is obstructed, it's like a funnel with a pinched spout. To figure out which kind of funnel we're dealing with, we introduce an intravenous loop diuretic called Lasix or furosemide. By inducing a massive, rapid flush of urine, we're basically doing a stress test on the drainage capacity of the system. If the tracer promptly washes out, you've got a wide spout. But if that tracer pools and just won't wash out despite the huge rush of fluid, we know for sure that spout is pinched. Now, to do this test properly, timing is literally everything. There are specific protocols for exactly when to inject that diuretic catalyst relative to the radioactive tracer. The standard go-to is F+15 or F+20. That means the furosemide is given 15 to 20 minutes after the tracer, right when the collecting system is totally full. But we have other options. F0 means they're injected simultaneously. And then there's F-15, meaning the diuretic goes in 15 minutes before the tracer. That one is incredibly useful for patients who have impaired renal function, like azotemia, because it gives the medication a head start to actually work. Section 3. Decoding the curves, translating tracer pooling into data. Visually, it's pretty easy to see the tracer pooling in the kidneys on a screen. But honestly, visual inspection just isn't precise enough for a diagnosis. So specialized software maps this spatial retention into a longitudinal time activity curve. A kidney that successfully clears the tracer will drop right back down to a baseline curve. But visual retention, that maps directly to a terrifying, continuously rising flatline response on the graph. So we need to quantify that curve. And the absolute magic numbers you need to remember here are 10 to 20 minutes. This is our critical indeterminate zone for the primary metric. But what exactly are we measuring? Let's trace the anatomy of this curve. We're measuring something called the T-half or T1/2 metric. Right at the top of that mountain peak is 100% maximum activity. That's exactly when we inject the furosemide. The T-half simply calculates how many minutes it takes for that tracer activity to fall by 50%. If it washes out in less than 10 minutes, the system is totally normal. If it takes more than 20 minutes, that system is definitively obstructed. And if it lands somewhere between 10 and 20 minutes, well, that's our indeterminate zone, which definitely requires a much closer look. These different washout speeds map directly onto what's known as the O'Reilly curve matrix, which basically identifies distinct functional clearance patterns.
A type 1 curve is a beautiful, normal, prompt washout. Compare that to a type 2 curve that's a high-pressure, obstructed system that just completely ignores the diuretic. The activity just keeps climbing and climbing. The matrix also maps out patterns for dilated but not obstructed hypotonic systems, equivocal responses, and even intermittent obstructions that give you this weird double hump shape.
Section 4. Avoiding diagnostic pitfalls. Conditions that compromise scan fidelity. As much as we rely on things like the O'Reilly matrix, we have to be incredibly careful. There are physiological variables out there that can completely tank the fidelity of this test. We have to be on high alert for false positives, where the scan screams obstruction but actually isn't. This can be caused by a distended bladder, gross hydronephrosis, or even just dehydration. And on the flip side, we have to watch out for false negatives, where a low-grade partial flow or poorly functioning kidney completely masks an underlying blockage, giving us a falsely reassuring scan.
Just look at the dramatic impact of a single variable, the full bladder effect. If a patient goes in with a totally full bladder, it creates massive artificial downstream back pressure. It literally prevents the upper urinary tract from draining, which creates a curve that looks totally obstructed. But take that same patient and put a catheter in the bladder, suddenly the system freely drains and reveals a completely normal washout. The takeaway here is absolutely crucial. Always, always consider catheterization in equivocal cases to just eliminate this false positive entirely. We also have to respect the patient's biological limits. If someone's glomerular filtration rate, their GFR, is under 15 milliliters per minute, their kidneys simply can't process the tracer or the diuretic fast enough in the first place. That renders the whole test totally unreliable. Same goes for dehydration. If the patient is dehydrated, you are not going to get a proper washout response no matter how much Lasix you push. Proper oral or IV hydration loading isn't just a suggestion, it's absolutely mandatory before the test even starts.
Section 5. The final verdict. Putting the functional assessment algorithm to the test.
All right, let's tie all of this together into a practical, real-world clinical workflow. Step 1 is preparation. Double-check that the GFR is above 15 and vigorously hydrate the patient. Step 2 is the intervention. Inject the tracer, monitor the pooling, hit them with the furosemide at the correct protocol time, and plot that curve. Step 3 is the analysis. Calculate your T-half metric from the peak down to that 50% fall. When you follow the functional assessment algorithm decision tree, everything becomes crystal clear. Once you have your T-half time, the algorithm takes over. Under 10 minutes, bam, you diagnose a non-obstructed dilation. You're safe. Over 20 minutes, stop and immediately check your pitfalls. Is their bladder full? Are they dehydrated? Are we looking at gross hydronephrosis? If you rule out all those pitfalls and the time is still over 20 minutes, you have your final verdict, a true mechanical obstruction that absolutely requires intervention. Let's put this into practice with a quick clinical scenario. Imagine a 32-year-old female patient who comes in with chronic right flank pain. Her anatomical scan shows a really swollen right kidney. But the functional evidence? It tells a completely different story. Her left kidney shows beautiful, normal uptake and prompt clearance. But that right kidney is poorly visualized, the counts just continually increase, and there is absolutely zero visible clearance, even after the Lasix is pushed at the 15-minute mark. The verdict here is undeniable. This isn't just a harmless dilation. That right kidney is truly obstructed at the ureteral-pelvic junction.
So, by assessing actual physiological function, we can totally solve the dilation dilemma. But I want to leave you with one final thought. If our current diuresis protocols can perfectly distinguish between a harmless dilation and a dangerous mechanical blockage right now, how might artificial intelligence and automated curve analysis algorithms revolutionize this entire process tomorrow? Could AI predict these blockages before the T-half time even reaches its peak? It's a seriously fascinating future to think about. Thanks so much for joining me for this explainer, and keep exploring.